less than 3% is the images in medical textbooks show skin conditions on skin of color. Unless a doctor is doing their residency in a city that has a higher population of skin of color, they're not going to naturally have that expertise.
Welcome to the Wellness Musketeers podcast, your guide to navigating the world of health, wellness, and the art of living. I'm your host, Dave Liss, a journalist and podcaster based in Washington, D.C., joined by my co-host, Dr. Richard Kennedy, an internist with over 36 years of clinical expertise. In a world inundated with wellness advice, we aim to provide actionable strategies to help you thrive. Today, we are thrilled to welcome Sheena Franklin, a trailblazing senior healthcare public policy professional and women's health advocate. Sheena is the founder of Kept, a groundbreaking digital healthcare company, and the force behind the health advocacy initiative All In. Join us as Sheena shares insights into Kept's business and strategic growth objectives and shed light on the critical health need and disparities facing women and their families across the United States. Sheena will guide us through Kept's business and strategic growth objectives and help us to better understand the needs and health disparities that women and their families endure across the United States. Before we begin, please remember to subscribe wherever you listen to this podcast. And if you're there, please also give us a review. 5 stars do amazing things for the podcast. And we'll keep bringing you all the different gurus in the health and wellness faith to explain to you all the different ways you can live your best life. And with that, here's our conversation with Sheena Franklin.
So less than 3% is the images in medical textbooks that show skin conditions on skin of color. Unless a doctor, dermatologist is doing their residency in a city that has a higher population of skin of color, they're not going to naturally have that expertise, right? And so that's what we were talking about. And then I'm Ronald is that when we first started out, we thought we would be able to use open source, data, research that we could partner with different academic institutions. But what we quickly find out that there was just a dearth of data on skin of color images. And so it became, well, how do we tackle that? Is it necessary? How do we do that? And so in order for us to actually have the tele-dermatology platform that we wanted to have, that we need to figure out how do we build out this data set. So that's one of the things that we're doing so that physicians can have the recommendations, at the point of care that yes, are this is the skin disease severity level. Well, this is also the skin tone. And then also because we focus a lot on women, we look at the underlying health conditions that may be, just a little recommendation, but not having our AI replace the physician. We're all about how do we make the physician, more precise, kind of decrease that burden that they have of being overworked and then just having it right there. Because what we found out a lot of times when we were doing research with dermatologists, they were pulling up 6 different screens in the office trying to figure it out and then having them go to notebooks where we're okay, let's just make it right there based on that patient and everything comes to you. So you don't have to figure it all out. Piecemeal it. So that's what we're doing. Yeah.
So can I ask a silly question?
Mm-hmm.
You guys reach out to the Howard, Morehouses, and Meharrys of the world?
We did.
And what was their response? Because one would think almost all of them are in regions where there's a large percentage of people of color. And you would think that, because to me, as a physician, one of the things that has always been the issue is there's studies going on all the time, everywhere. But for people of color to access them, first of all, there has to be a way for them to be made aware that it's even there. You have to get through the bias that exists is that we don't trust the healthcare system.
Mm-hmm.
And that the first thing you look at is that any research on us is I'm being used as the guinea pig for some nefarious thing. Well, I was wondering how when you reached out to them, to the Howards, the, historically Black institutions, what was their response? Because one would think that if anybody has access to a greater cadre of people of color, they have.
Yeah. So we talked to Howard. So one of our advisors, who's in the company, is a professor over at Howard. And so we got very far along in conversations, and disappointingly, they decided to work with GW. So a professor that actually was a sponsor for me to get funding for the National Science Foundation. So he decided that he wanted to create a database of images that are only going to be used for education purposes. So they are working with him to build out this system, which creates, like, we were trying to work together, but because they're collecting this for education, it can't be used for commercial reasons, right? So like there's all these stipulations, right? And so then, I have like the Eli Lillys of the world coming to me like, hey, can you provide us with images? And I'm like, well, not yet, but maybe in the future, because they have that same problem too. It's like they were doing a big study on contact dermatitis, and they just didn't have enough images. And so it's just a big scope. Okay. So they decided to work with that institution instead of working with us. That's what happened.
Okay.
That's probably another different type of podcast. But yeah.
I think it's important to know because it creates the difficulty of what you're trying to do and sort of try to target something that really is not present out in the community. You always find a way to say, well, how is it that we keep talking about the health disparities? And, you hear about it on Capitol Hill, you hear about it in every institution, and everybody states how much they want to, get rid of it and eliminate it, but they don't think they have a good plan on how to reach out, because until you reach out to the communities affected and make them feel welcome in some way, shape, or form, health disparities is going to continue.
I definitely agree. Two things. One, I think it's expensive. To be honest, it'll be expensive. It's hard. And the reason it makes it hard is I found working with them and some other life sciences companies that I was interested in working with, you can't use the same model, right? Like you have to change the model and you have to create the environment where it's more comforting, right? Like I feel like the person who's doing the research, the nurse that is there is welcoming to me. Like you're not just coming in this one-time shot and then I never see you again. Like what are you doing before and after that's creating this environment of trust? I don't think people, in these communities are saying, no, we don't see the value in participating. It's what are you doing to tell me what's going to happen even after this day? Like what's going to happen? Like I think there's like all these nuances where people are like, just come up. We can just have a Black woman and she'll bring everybody and then we'll just go on about our business and who cares? That's kind of the attitude.
Yeah, it is. I admire you. I respect everything you're trying to do. It is a monumental task to me, partly because if you just randomly talk to any person of color, whether they have an interest in healthcare or not, almost everybody's heard about the Tuskegee Study. So, or what happened to, what's her name? The woman?
Henrietta Lacks.
Henrietta Lacks. And so, or find a way, because again, lots of good information did come out of all of those things. The problem is that, one, some of it was done in secrecy, decades. And then even after that had happened, the distrust it's just there. It's palpable.
Yeah, yeah. So, well, for us, there's a couple of things. One, so we don't do clinical trial research. Like that's not that's one thing, right? That makes it a little bit easier for us. The second thing that makes it easier for us is because we're doing skincare, which fundamentally women are always taking pictures of their skin anyway, right? We're like, we'll go to Ulta, we'll go to a dermatologist, we'll go somewhere like, help us figure this out, right? So that's kind of our approach there, which helps us out a lot. So like if you go to our mobile app, it's like we're just helping you do what you already do. And we're saying, by the way, because you're doing this, you're helping to expand us to get better care for you down the road, right? So like it's that type of attitude. So we're not saying participate in this clinical trial.
Okay.
Yeah. But we still go out and educate people on, why it's important just to share your data, like just why you should share it in general. And it's happening. So then are you more proactive when your app and your phone is taking all your health data and you just really don't know it in general?
Mm-hmm. That's very helpful. So now how, in the perfect world, how do you think this would benefit particularly women? Because like you say, women are more conscientious and aware of their physical attributes and are more willing to address it, let's put it that way, compared to us men.
Yeah. So with our company, our whole goal, like our health moonshot goal, if you will, is to decrease the rate of misdiagnosis of skin diseases and their underlying health conditions that disproportionately impact women. So if you might think about like autoimmune diseases, right? Mm-hmm. So like there's all these studies that come out, and one that just came out that said dermatologists are usually the first people to spot like those illnesses because it's impacting our hair, like hair loss, right? Mm-hmm. So like that's our goal, and that we want to be able to decrease that. And while decreasing it for all women, to make sure that women of color are on par with their white counterparts. Like, we're not just ignoring them. So like that's our health like moonshot, right? Like on that day-to-day basis is just getting women to a quicker diagnosis, right? And getting them to a doctor quicker. So if it's taking people 3 months, like how can we get someone to the doctor when they're on our platform within 24 to 48 hours to get that initial diagnosis and then triage that care, right? And knowing that everything can't be treated telehealth.
Right.
If we know like, hey, this is a severe issue, then how do we get someone into the doctor within a week, right? So that's like the goal. And then helping them maintain that and manage those flare-ups. Mm-hmm. That's our like goal there. And then thinking about our company bigger is like, we're having this data. So how do we create what we call like a FEM index that has that information there? Mm-hmm. And then how do we de-identify all that data and package that up so like we can help advance research just in women's health or advance research for government institutions who are trying to appropriate funds for women's health and research, right? Like so that's our goal. But initially the core of what we do is making sure that we're getting women the care that they need.
Okay.
Like we see it as a cycle.
Yeah.
We all need each other in order to get to the next point.
Good. That's actually great. Do you also, as you mentioned earlier, to getting earlier diagnoses and getting people to be seen in a timely fashion, have you already started to create a referral network?
Yeah. So we have a network that we're building internally. So right now we have 150 doctors and estheticians and a couple nutritionists, dietitians as well. And we're continuing to grow that over time. And one thing that we're looking into right now is how do we partner with like the skin of color clinics, like at the Cleveland Clinic, the Mayo Clinic, and to bring them into our network as well to expand it. So instead of like one doctor here, one doctor there, one association there, I think we're doing that, but forming those partnerships as well.
One question I was worried about is if I'm in Mississippi and all of your care providers are not in Mississippi, can I still get care from someone on your network, or do they have to be in my state?
Yeah. So that's the law, the telemedicine law. the doctor has to be licensed in that state. Now, say, for example, I could have someone on my team that may have practice, like, say, like in Georgia, right? And Georgia has, blanking out on the word right now, but you can get a multi-state license, but it's usually by region. So like I could have someone who's in Florida or Georgia, but they have a license for Florida, Alabama, Mississippi, right? But they have to have that license there. So that's how we do it. But also, we'll also provide people a listing of names. Like, say, for example, we don't have that person. We're not in Mississippi quite yet. We will provide you with a list of vetted doctors and people that we would say, hey, go visit this person. Like, that's a challenge with growing a telehealth company, right? It's like, getting all those ducks in a row.
Yeah. Since the pandemic, there are regions and much of the United States is set up in sort of reciprocal acknowledgement. So when I was in Maryland, I had a license in Maryland, DC, and Virginia. When I was in New York, I had a license that was New York, New Jersey, and Connecticut.
Oh, okay. Connecticut.
So now that I'm in Texas, one, because I decided I don't want to practice anymore, but Texas, Oklahoma, New Mexico, Colorado are part of the conglomerate. There's a website where physicians can go and sign up one time, because the real problem in the past, you'd have to individually go to each jurisdiction and apply for the license.
Yeah.
Which pricey, $800 to $1,500 a pop.
Yep, depending on what state it is. Absolutely. Yeah.
And so, what they've done now is that because telemedicine is here to stay, and the federal government has sort of said, yeah, it kind of makes sense, because there's going to be times where it would be ideal in many respects to see someone in the locale where you are. It makes perfect sense. Also, just to develop a relationship, because telemedicine has its benefits, but if I'm in California and the patient I'm seeing is in Virginia, we may have a wonderful time each time we go to our television. But in that crisis emergency in the middle of the night at 2 a.m., when I need an answer, I may have an on-call service that'll help, but the standard reply is going to be, this is an emergency, call 911 and go to the nearest facility. And it would make sense to have somebody who's locally there, who can look out.
Mm-hmm. I agree. Absolutely.
What you're undertaking is a wonderful thing. And actually, you're right, thinking out of the box and not thinking of it solely from the perspective of television, but also a combination of in-person visits and television. So that's
exactly. It has to be. And then once our AI gets, more mature, what we plan on implementing is, once you start that visit, you will scan your skin. And if immediately we know, like, this is a high severity case, we're going to route you automatically to an in-person visit. Or if we see something, like if now we have these underlying health conditions, like someone, we're like, oh, you have like a butterfly rash. Mm-hmm. We think this might be lupus. We're going to send you right off of the platform. We're not just about making a buck, right? Like, go make enough money, right? So it's like, yeah. So that's one of the things that we're also working towards. And that also helps us reach our moonshot of like decreasing this misdiagnosis rates all the way around.
Two things I was wondering is men a universally different consideration, or would men be something you would evolve into over time? And, I think like somewhere we would probably want to talk about like your 1, 3, 5 year vision for like, where you are now, where you want to grow, and the like articulation of sort of how that would evolve into the moonshot kind of thing.
Yeah. So I will say right now we are a women's health focused company, just because there's like some health disparities there just in general. Now, when we look towards the future, yes, I want to get to the point where we are caring for men as well. Obviously, that's going to take like different branding, different marketing, but that is a goal. And then we also want to move into adolescent care as well. So like those are like the long, like 10-year goals, if you will, for the company, and moving into those different patient populations. And then also 5 years from now, basically what we want to be able to do is I tell people, we want to take care of women today and folks today on their mobile phones, but in the future at their favorite like pharmacy and retailer. Because again, we're doing the skin, scanning the skin. What does that look like, right? So say, for example, let's take a rural area, right? There's always a Walmart, a Subway, and a Dollar General. Like you can always bet on one of those three things, right? So what does that mean if a farmer is coming into, Walmart and they do like, there's a cat station there and they can have a scan and they can go through the doctor can look at these different things. And then they can say, okay, now I can schedule these visits, and so I can only take one trip. That's going to be 3 hours in the city for the doctor. And the doctor can have this information. That's what that looks like for us. Or it can be so as simple as someone's at Sephora, right? And Sephora, they're not really trained. Like, let's just be honest, right? 1 week they're at Subway, the next week they're at. So it's like they're scanning their skin. They're like, oh, okay. Like, we think this will help you with your condition. You can set up your profile and then you can monitor your skin like throughout the process. And then if something comes up, then you have that telehealth opportunity directly on the mobile. So like it's about a complete picture of skin health, as we call it.
So how do you reach the individual? The time that you reach them to the time that they end up in care somewhere. Can you sort of take me through those steps, how the process works? And also me not being technologically advanced at all, with you saying scanning and this and that.
Yep.
How would a person who's 60 years old, who's not familiar with all this technology, who's concerned about their skin because they want to, they got to get ready for their daughter, their son's wedding, want to look good. How do you help them along the way?
Sure thing. So I say there's a couple ways that people learn about us, right? So we do a lot of direct to consumer because just the nature of skincare, dermatology, right? So people can find out about us through like ads. We don't do a lot of ads, but some ads, right? We work with a lot of women's groups and organizations. And then we work with a lot of like for other types of physicians and dietitians and wellness experts who refer people to the mobile app. So you download the mobile app, right? You log in, you have an option of doing like a wellness questionnaire that asks questions about supplements, your diet, your exercise, because this all will help inform the physician that you're connected to. And so you come on for your visit, you click on I want to do a visit. Okay, perfect. So then you do your standard medical intake form, which is required by law, right? And then we ask you to take 3 photos of your skin. We give you instructions about it needs to be, well lit, no makeup, no glasses. Then we instruct you to take one close up, a regular length, and then far away. So the doctor can have these 3 different visuals to look at. Excuse me. And then at the end, when you reach the end of the visit, you click submit. So this is all asynchronous, right? We don't do synchronous. So store and I don't know that. So asynchronous, no live visual. You click submit, then that goes to the back end, which I'll get to. But we're just focused on the patient. And then within 24 to 48 hours, that you will get a ping in your mobile app that says, hey, your treatment plan is ready. Then you log back in, you click on, we have a section that will have all of your visits with us and it's labeled by date, and you will open it up and it will say, this is your diagnosis. This is who you saw. This is the date. This was your concern. Again, this was the diagnosis. These are a prescription. If you need it, click this button so you can get your prescription filled, e-prescribing. We don't do that on the back end. We have a service that does that. And then we'll also offer like some lifestyle tips, right? Like that says like, we notice that, you know, you have rosacea, like lots of drinking is going to make that worse. So you might want to just general tips, cut down on that, use like a light moisturizer, and then come back for a follow-up visit in 6 months because it's not necessarily that severe. And that's all it takes. It's that simple.
Do you have something like this like on YouTube?
No, we have steps on the website. If you come to the website, and it's also once you're in the app, like it's going to be pretty self-explanatory. Like we walk you through each of the steps. It's not difficult, honestly.
Are you using mid-level practitioners, PAs, nurse practitioners who work in dermatology office?
So right now we're focused on dermatologists simply because our early target market are women of color. So we are like working with folks who are really experienced in that area or they have an interest in that area and they're going to get continued education. And also folks who are doing a lot with functional dermatology, functional medicine as well. So when we were in our private beta, went through a lot of research, had 2,000 women, a lot of people wanted a dermatologist. Like I wanted my first visit to be with a dermatologist. Like the follow-up care, that's great, but I want a doctor. So that's who we're focusing on. We're going to try it, see what happens.
Yeah.
Well, not that many dermatologists.
Have you guys reached out to the NMA, National Association?
Our advisor is a past president. So they're working with us as well. Yeah.
Because I think the other thing, and again, this from my own experience, is that mid-level practitioners, not that they're not qualified technically, it all depends where they are, what kind of training they've had, how long they've been in practice themselves.
Yeah.
There's so much variability in that these days. And also in most of the world, we're used to the doctor. And I say that because I was once the physician assistant. I remember all the times I would walk in and say, I'm Mr. Kennedy. And by the time we left, they say, thank you very much, Dr. Kennedy. So, you know, I have to hear it all the time. And you get tired of trying to explain the difference.
Yeah.
To a patient, it suggests that, gee, you don't think enough of me to have a doctor come in and deal with it.
Yeah.
But how, you know, and there are lots of reasons why mid-level practitioners are important, but the reality is that they still don't have the training that physicians get. That's just a fact.
Yeah, absolutely. That's what we found too. So, you know, it's about finding the happy medium. And like I said, the follow-up care, they're a little bit more open to that. MP or admission or something like that. Yeah.
If I'm in Canada or Mexico or Venezuela and I find my way to downloading the app, can I get care?
It's a good question. So technically they say you can. This is the law. Technically the law says you can, but it has to be where you're a resident, right? And so that's one of the things that we do is in the back end, how the technology works, we ask you your address. Like we're going to know like what state you live in. And then we'll be able to tell like the geo tracking where you actually are.
Right.
Right. So we would route you to a physician that's in your state. Maybe if you have that good of an internet access, but
is it also like if I'm 85 years old, if I'm 90 years old, I mean, is that within the universe of people that you would serve? Or is it like, well, our primary care service area, people in this age, some age range?
Yeah. So we're talking about marketing, like our target market is 30 to 55. Like that's our target market, right? Now there's people going to be outside that ranges that uses it. Now, when we start talking about like elderly, I probably don't think an elderly person would be doing it on their own. They would probably have a family member, a caretaker that's helping them do that, right? That's typically how that would work. And the process would be the same. But I would probably think if an elderly person was coming with a skin condition, it probably would be something severe that needs to be seen like in the office, right? So like we're asking you your age, we're asking you all these different things. So by the time, the doctor sees it or the AI sees it, when it gets to that point, we're going to have some checkpoints in there. But theoretically, yes, you can use it. Like anybody could use it.
So in an interview like this, what are the 3 or 4 most important messages that you would want to get out about what you're doing, what you want to build, what you're building?
Yeah. The first one is that one, we want to help get women the care that they need in a timely manner, right? And when they're doing that, we want to ease the frustration and anxiety that women experience and women of color experience when they go to the doctor. That's the first thing. The second thing is like, we're going to help you get the most accurate diagnosis the first time around, right? Like that goes to decreasing that diagnostic rate. And then 3, we're going to stay around to help you manage your skin concerns or any other health condition you may find out, right? We're not just dropping you off. And those are the 3 important things that I want people to know. The bonus would be by joining our community and, using our app, you're helping to better the care of other women in your community, just like you.
Becomes word of mouth.
Mm-hmm.
Very much becomes word of mouth. I'm assuming you've launched it already.
So we launched part 1. And what I mean by part 1 is, I was saying to Dave before, we're still building out the back end with the EHR, like with our vendor.
Yeah.
Everything else is there. So right now you can download the app. And if you need to see someone, you will click on the button, tell us what your concern is. And then we send you back a list of all of our doctors in your state that are in our network. And they will work with you to set up an appointment. In the fall, you'll be able to have that full telehealth experience. It's just
Okay.
taking a lot.
Are you already connected in?
So we have most of like the eastern seaboard, south. So I would say we have we're not in Mississippi, Alabama, Iowa. And the reason why I say that is because the company that we're working with, they're called Open Loop. And so what they do is they file the paperwork for us to be practicing, that we can practice in every state. Now it's just about finding dermatologists in those states.
No state.
Exactly. So we can practice throughout the U.S. It's just about, are we going to find the number of doctors that we need in those states?
Right. Interesting that you're not in Mississippi when there's Meharry.
So Meharry, isn't Meharry in Tennessee? Mississippi, Alabama, they're very different states, right? And then you have a lot of the population that have government assistance, which makes it a little bit more difficult for us because we are a cash pay, right? Because sometimes dermatologists, they like cash, like they don't accept lots of insurance and Medicaid and Medicare and all those things. So
they like help provide.
Yeah.
So would it be the kind of thing where maybe 5 years from now, I have United Healthcare and they would say, download this kept app and then that'll help you with your skincare guide?
Yeah, that's possible. Yeah.
I don't know. But I think...
No, they do it. It's just because we don't take insurance, a lot of the payers don't necessarily want to work with us because we don't take the insurance. And the insurance company is the insurance company. That's all.
It was interesting a couple of years ago, this pre-pandemic, I worked with the organization. They're trying to do telehealth and basically chronic condition, high blood pressure, diabetes, things like that. And then the issue was none of these doctors wanted to work with it because they didn't believe in the idea of telehealth. And then, come the pandemic, then also it's the most viable option out there. And I don't know how some cataclysmic event is going to encourage something like this for adaptation.
That was interesting. I think it's also, I'm not a physician. I only talk to them and I have them on the team. So I'm just going to give my layman perspective is I don't think they understood how it would benefit them. I think they were thinking that they weren't going to have the same level of care, right? or they weren't going to be able to see the same number of patients, and somehow they weren't going to get reimbursed by the insurance companies, right? So like that was, I don't think fundamentally like they knew it will work, but it was like all the other little tangibles if it was going to be worth me doing it, right?
It was the back end.
Yeah, it's the back end. And then a lot of times, to be quite honest, not that I have anything against like my fellow founders who are in healthcare, it's like a lot of the tools are so burdensome just to even incorporate into your practice, right? So now you want me to spend hours and hours training someone to do something, and then it doesn't work. And it's just a lot, right? Like sometimes those systems aren't just easily integrated into what the doctor is already doing. And it just becomes a hassle. So, and it's clunky on the back end, you know, like I'm trying to enter a CPT code and then the code won't go in. So then I have to go exit out of your system and then just go back to the way I was doing it, right? So, you know, there's a lot of different things.
So where do you see yourself in the next 3 years?
Oh my gosh. In the next 3 years, we will definitely be able to have our AI like functioning, right? So that will allow us to bring on more of those mid-level doctors or less experienced doctors because the AI is going to be making more accurate, you know, recommendations to them. I want to be close to having served at least 1 million women, like getting closer to that number and building out that FEM index so that we can help other agencies, you know, medical device companies. That's where I see ourselves in the next 3 years. And maybe working with a larger health system and spreading the message of like what we're doing, like partnering with them in some type of way.
That's going to be an interesting task for you just because people like to have their own, what's the best way of saying it? They want to always take credit for things they didn't always do. And you're clearly doing something that's different. And it is interesting that you're starting with skin because, as Dave mentioned earlier, there are lots of people who talk about diabetes, hypertension, depression, anxiety, etc., and health and cancer, etc., things like that. But you've sort of really targeted, first of all, I think it's ideal that you targeted women because if you targeted men first, you'd still be at the drawing board 2 years later, just because, as they say, we have to be dying to get in the door. You know, there's a whole lot of issues with that, and that's across all culture.
Yeah.
But if you add the fact that people of color and the lack of trust in the system and doing good by you, so it's better if it's not bothering me, I'll get to it when it bothers. Unfortunately, that's what leads to the greater terminal and the higher mortality rate in Black men in this country. It's that because we're no different than all men, except that since we don't trust, we'll just push it to the side. And if you add poverty to that and you're trying to make ends meet, you know, where you have to decide, am I going to pay for this medication or I'm going to put food on the table to feed the family? You know, there's kind of no real choice. You know?
Yeah.
Sad it is, but it is a reality.
Yeah. And that's just the complexity of the healthcare system, right? Like you need it, but sometimes you don't trust it. And then the cost can just be so detrimental to your family, right? Like,
oh yeah. Healthcare is extraordinarily pricey. And also, you know, I've always been a firm believer that it should be access for everyone, regardless. And that's never been the case. I mean, it's never been the case. And because everything is so tied to all of the newer invention, the newer drugs, all of those things cost constant. More than that becomes an issue, you know. And so things that we should be addressing that would improve the health of all, we don't because it costs too much.
It takes too much time. But we'll get there. Maybe not in our lifetime.
Yeah, that's true. Okay. Most people.
Maybe.
We're trending there, right? Is that what they say? We're trending in that direction.
It's a long road, but you have to keep trying. And that's all you can do. One step
Yep.
at a time.
For sure.
They say small step, small victories, get bigger each time. No question.
Yep, absolutely.
Well, a huge thank you to our guest, Sheena Franklin, co-founder of Kept and All In. To learn more about Kept and their work on advancing women's health and skincare, please visit https://www.kept.health. Thank you for joining us for Wellness Musketeer. Tune in for upcoming episodes to learn how to live with a greater understanding of the world we experience together. Please subscribe, give us a 5-star review, and share this recording with your family and friends. You can make a contribution through the link provided on our program notes to allow this podcast to grow. Let us know what you need to learn to help you live your best life. Send your questions and ideas for future episodes to Dave Liss at davidmliss@gmail.com.